Welcome. I am Ingrid Scheffer. I'm President of the Australian Academy of Health and Medical Sciences, and we're excited tonight to bring you a vision of the way forward in the time of COVID-19. Let me begin by acknowledging the traditional custodians of the lands, of the many lands upon which we meet, acknowledging that individuals are joining this webinar from across Australia and indeed the world. The Indigenous peoples of Australia were our nation's first scientists. I would like to pay my respects to the Indigenous peoples who remain the spiritual and cultural custodians of this land, and in particular, pay my respects to elders past, present and emerging, and look forward to our future together. I would also like to introduce the Academy, which is Australia's Academy of Health and Medical Sciences, and we provide an impartial, authoritative, cross-sector voice of health and medical science in Australia. We comprise an interdisciplinary body of almost 400 fellows elected by their peers for their outstanding achievements and exceptional contributions to health and medical science in Australia. Collectively, our fellows represent an independent voice through which we engage with the community, industry and governments. The Academy is uniquely positioned to convene cross-sector stakeholders from across Australia to address the most pressing health challenges facing society. COVID-19 is an important example of just such a challenge, and hosting this webinar is just one part of our activities to address this critical global issue. We are also active in providing advice to government, for example, through the Rapid Research Information Forum chaired by Chief Scientist and Academy Fellow Dr. Alan Finkel. This expert forum provides a mechanism through which government receives input regarding the science and evidence-based responses to queries about COVID-19. Tonight, our webinar brings together interdisciplinary perspectives to review the current situation of COVID-19 and consider what the road ahead holds. We will consider how Australia and the world can achieve recovery and resilience as we work through this pandemic. We have an outstanding panel of leading experts from infectious diseases, epidemiology, intensive care, mental health and economics. I'd like to extend my warmest thanks to our chair and panellists on behalf of the Academy for sharing their expertise with us tonight. I'd like to now introduce our chair, Professor Shitij Kapur. Professor Kapur is Assistant Vice-Chancellor Health and Dean of the Faculty of Medicine, Dentistry and Health Sciences at the University of Melbourne. He is a psychiatrist and neuroscientist and has devoted his academic career to finding better treatments for schizophrenia. His work has had a significant impact on our understanding of antipsychotics and how to make the best use of them. Shitij has practiced medicine and conducted research in many regions of the world, from UK, Canada, India to Australia. He is a Fellow of the Australian Academy of Health and Medical Sciences and is also a Fellow of the UK Academy of Medical Sciences. Thank you so much, Shitij, for your chairing tonight.
Good evening. My name is Shitij Kapur. I'm the Dean of the Faculty of Medicine, Dentistry and Health Sciences here at the University of Melbourne, and of course a member and a Fellow of the Academy. We're here today to talk about COVID-19. Well, what else is there to talk about? But COVID-19, where to from here, charting a course to resilience and recovery. And here's how we'll go about it. We will first review what is the latest knowledge about COVID-19 with the experts who are with us today. We will then talk about how Australia can go from where it is to a recovery, but then actually flirt with the notion of resilience. Could we be even better than we were before we started with COVID? So for that and more, we have about 90 minutes. The first 45, we'll have a conversation amongst the experts and hear what their views are, but then we're really interested in your questions. And there are two ways in which you can get your questions to us. One is on your Zoom, you would have that little thing called a chat box. You can just write out your question in the chat box. But as you're writing out your questions, you might also see there are other questions already there. And if there is a question you like, you don't have to repeat it. You can just go and upvote it and it gets slightly higher recognition. So you can write your questions, but we'd also like the opportunity for you to come and ask your question. Now, if that's what you'd like to do, please put your name and your question and email it to events@aahms.org. And that will keep appearing on the screen so that you can see it. It's events@aahms.org. So you'll write to them and they will then invite you through Zoom into our virtual waiting room. And once you're there, we'll let you in and then you can ask your question directly. But that'll happen in about 45 minutes. But first, let me turn to our experts. And we have a wonderful panel here today. Let me start with Professor Sharon Lewin. She is the director of the Peter Doherty Institute for Infection and Immunity. She's, of course, a fellow of the Australian Academy, but also, as it happens, to be the leader of the Australian Partnership for Preparedness on Infectious Disease Emergencies. It's called a PRIZE. And of course, if you've been watching your TV lately, you would certainly know Sharon. So I'd ask Sharon to wave if you could. Thank you. And then we have Kamalini Lokuge, who's the lead of the humanitarian research program at ANU. She's a medical doctor and an epidemiologist and someone who's been there and done that. So she's an expert in public health response. She has worked in the control of high-risk infectious diseases like Ebola, Lassa fever, and avian influenza. So she brings on-the-ground experience of what it means to manage these epidemics. And then we have Professor Steve Webb, another fellow of the Academy. He's a senior staff specialist in intensive care at the University of Western Australia. He's been taking care of patients with COVID and has also been a part of a leading trial called REMAP-CAP trial, which is looking at the various remedies or therapeutics that are available at the moment for COVID-19. And then Warwick McKibbin, who's an economist. He's the director of the Center for Applied Macroeconomic Analysis at the Crawford School at the Australian National University. He's an economist and a former Reserve Bank board member with one specific interest in the economic impact of pandemics. He's worked previously on SARS and avian influenza, and he was one of the first economists to get on the issue of what this might mean for us. And then finally, a special pleasure to welcome, for someone for whom it's a morning, it is Professor Simon Wesley. A good morning to you, Simon. Simon is the head of the Department of Psychological Medicine at the Institute of Psychiatry in London, where I had the pleasure of being a colleague of his for about 10 years. He's one of the foremost psychiatrists in the world, and I don't use that word lightly. Highly published, highly cited, but most importantly for us here today, a special expert in the area of response to trauma, be it in the context of war or disasters. So we have a wonderful panel here, but perhaps I should start with you, Sharon. Tell us where Australia is today and how are we doing?
Thank you, Shitij. Great pleasure to be here and thank the Academy for hosting today. I'm going to share with you something called the Australian Dashboard. I look at this every day, actually. I don't know whether other members of the Academy do the same, and I think this is just a great way to give you a snapshot of what's happening in Australia. I assume you can see my slides at the moment?
Yes.
Okay, so I'll just show you the highlights here about what's happening in Australia. We've had over 6,700 cases, 84 deaths, and 5,600 recovered. And these two numbers don't add up to 6,700 because there's still people who are unwell or still have symptoms and don't classify as recovered. The most important part of this dashboard, I find, is this graph here, the daily numbers of reported cases. And what you can see here is a classic epidemic curve. These are the number of COVID diagnoses, so throat swab positive, in Australia, starting back in about mid-January. And you can see that around early March, this began to take off. Numbers of cases every day, classically increasing as the outbreak was uncontrolled, peaking at around 400 cases today at maximum. And then from about late March, every day are numbers of new cases slowly decreasing. Extraordinarily proud of seeing an epidemic curve like this. Not many other countries have it. And we're down now to around, low numbers, around 12 cases in the last 24 hours or 27 in the last 48 hours. Pretty extraordinary. And so when people talk about flattening the curve, we have absolutely flattened it. And I prefer the term squashing the curve. Another interesting graph on this little dashboard, I think, is around mortality. And this is summarized here. You've got the mortality, the numbers, this is raw numbers, in men in blue and orange and women in orange. And you can see here that most of the deaths, or all of the deaths, are in the older age group, with the highest numbers in this group, 70s to 80s, and more common in men than in women. We can talk about that later. And overall, this pattern is exactly similar to patterns reported initially from China. And finally, the last thing that we track carefully is the sources of infection. And this shows you the summary for Australia overall. And in blue is overseas acquired, and that accounts for about 2/3 of our infections. In orange, contacts with a known case. And then in green, what's loosely called community transmission, which means that we don't know the actual source. And so overall, I would say that, we've done extraordinarily well in Australia with tiny numbers of cases, with large efforts, of course, with, I think our big strength has been testing, efficient public health response with quarantining and isolation, and of course, our social distancing measures, which we were all introduced roughly around the country in the last week of March, which have had an extraordinary impact. And the situation we're facing now, of course, is the heavy economic impact that this has led to within Australia, and then how we exit from the current range we're living.
Thank you very much. Sharon, can you just leave it there? Because this is a good segue for me to get to Steve. So Steve, you of course take care of the end where it says 109 and 42. So tell us how it has been like in hospitals taking care of these patients.
Thanks. We've certainly had a much more limited exposure to COVID in the intensive care units in Australia than has occurred elsewhere in the world. We've had nothing like the overwhelming number of cases that have occurred in Italy, in New York, and in London. It's quite a challenging disease to manage. It's quite distinctly different to other forms of adult respiratory distress syndrome and overwhelming multi-organ failure that we're used to seeing in ICU. In particular, there are sometimes late and unpredictable deteriorations in patients. That's not a feature that we normally see in critically ill patients. And although some patients are dying as a consequence of respiratory failure, we're also seeing a quite unusual syndrome of unsupportable hemodynamic collapse with, despite administration of very large doses of inotropes and vasopressors, inability to keep people alive, unfortunately. As a consequence of the issues that Sharon was talking about, with this really wonderful squashed curve, we've had the opportunity to have much more preparation and planning than has occurred elsewhere in the world. One of the dominating features of the experience for intensivists in other countries has been rapidly being overwhelmed by a large number of patients. I've had colleagues in Paris who talk about placing a patient on a ventilator every hour as they come, as this enormous wave of patients comes into the intensive care unit. We've had many weeks to prepare and plan, and as a consequence, the Australian intensive care system is really remarkably well positioned if we're unfortunate enough to see substantial numbers. We can certainly move to at least double the number of ventilated patients than we would normally be capable of, and perhaps even as many as 3 or 4 times the number of ventilated patients. Perhaps just the last aspect to mention is the overwhelming number of treatment options which intensivists have available, with no evidence whatsoever to guide those treatment options.
Right, you've not been obviously listening to the White House briefings, but I'll leave that aside, Steve, for the moment. And look, it's a fortunate place to be in. I hesitate in using that word because you almost feel that you're hostage to fortune when you do. But it is a fortunate place we are in, where the numbers are very low, and that has, of course, led to the possibility that perhaps we could eliminate the virus from Australia, from the continent. Kamalini, you've been thinking a lot about these things. You've dealt with viruses in other countries. You probably never thought you'd be dealing with one here. What is your thought on where we go from here?
I think the first thing to say is I don't think it's good luck that we're here. We're here because the Australian community, they did what they needed to do. So we know through a lot of different sources of data that probably over 80 to 90% of the population did social distancing. So I think it's important to recognise that it wasn't luck. It was the community acting when they needed to and supported by the health system and policymakers to do so safely and effectively. So I think that's important to state.
That's a good point to make. Yes.
Yep. So because of that, because of what the community took on in terms of response, we are in a position where, as Sharon said, we have a handful of cases, maybe slightly more. And unlike many of the countries, I'm sure Simon is going to talk about the situation in the UK, we have the resources and the capacity to aim for identifying every single case in our community and managing that so that it doesn't spread. And I think that's where the next focus is. And, again, the public needs support to do that. They need testing capacity. They need, places to go, to get tested quickly, to get results quickly. But it's, again, going to be the community that deals with this. If everyone who has mild respiratory symptoms, fever, cough, the current case definition goes to get tested, and we give them results quickly and we manage them appropriately, then we very much, I think, should aim for getting rid of every case of community transmission.
So Kamalini, can you just tell us what would be your scientific or technical definition of elimination in our context? When would you say?
If we look to other diseases we've worked on, so we don't actually define elimination of polio just by saying we don't have polio in a country, because if we're not looking for polio, we won't have cases. So the way we should be defining getting rid of transmission of COVID-19 in our community is, have we got the system to know that it's not there? And that comes back again to not even how much testing we're doing, but of all the people in the community who should be getting tested, what proportion are being tested. And that's our whole community, but it's also groups within our community who generally don't go to healthcare because they've had bad experiences, because they don't have the resources. So we need to support every section of our community to engage in this process. And what I think we can be confident of is, if we do it the right way, the health system supports the community. If policymakers support the community, we can get our testing levels up to a position where we can say everyone who might have this disease is being tested, and therefore we know it's not there.
Now, Kamalini, you of course point to the fact that symptoms could be the trigger for test. Now, of course, we'll soon be heading into winter. Lots of people will develop sniffles and coughs and a bit of fever. How are we going to, in that context, figure out what's going on? Yeah.
We've done work, and we have now, we've done a great job, our laboratories, our public health system, in scaling up testing. And we know that we have capacity to test widely, including what we are likely to see in terms of levels of coughs and flu-like symptoms. But we also know from settings, including our setting, we've had a massive drop. The levels of those sorts of symptoms in our community is much lower than we would expect for this time of year. So we've had a drop because people are social distancing. They're using, hygiene, they're washing their hands, they're being careful. So we know we have the capacity to do that testing. What we really need to focus on is making sure, it's a big shift. And right up until now, we were telling people, get tested in case you have COVID. We need to shift to saying, get tested so we know you don't have it.
But I understand, and Simon could probably tell us that, UK decided that it was going to allow much more testing, and they opened the website and everyone registered and wanted the test, and the website collapsed or something to that effect. So how do you send out a public message which just gets the right people to come out for testing, not all 25 million of us? So what would that message be? Who should come and get tested in that strategy?
Sorry, Shitij, that's a question at me. I'm not sure.
It was to Kamalini, but...
Okay. Are you asking me?
Yes, indeed. Sorry, you're a bit frozen on the video, but probably not by voice. I was just wondering, how would you phrase your next step up of testing along the lines of an elimination strategy so that just the right number of people come?
I think the current definition the government recently put out is the right one. Fever, respiratory symptoms. And we know that there are people who are infectious with COVID who might not meet that case definition, but we don't need to get every single person. What we need to do is identify every single transmission chain, which is every single group of people that are linked. And what we can be certain of is within such a transmission chain, there will be several people, hopefully, what we're aiming for is not getting any transmission chains, but we will find people with symptoms. We find them early, we detect any transmission around them, whether it's symptomatic or not, and we manage that effectively. And again, because of the hard work of the Australian community, we're in a position where we have the resources to do that.
All right, well, thank you very much. And Kamalini, you raised a very important issue of an emphasis on transmission chains rather than an individual, and I'd like to come back to that. But a good time to turn to Simon. Simon, you've been observing what's happening in the UK. You've been looking at the picture here. What goes through your mind when you look at this?
Well, it is very different in the UK, very, very different. And our dashboard just doesn't look remotely like yours. We are still in the middle of a very serious crisis. We have 170,000, I think it is now, confirmed cases, but clearly a lot more. We're getting 5,000 a day, new cases, clearly though a lot more. And the deaths are now 21,000, I think, as of this morning. And the rate of increase of deaths has steadied, but it's still varying from 500 to 800, maybe 1,000 a day. So we've still got a long way to go. So yes, and the epicenter is, as someone's just said, London. It's not quite so gloomy in the rest of the UK, but of course, we are expecting that will change, as almost inevitably it will. But yeah, it is very different. I think we're already in the midst of a round of recriminations as to why this is, and that's only going to get worse. And there will be inevitably huge-scale public inquiries to see what did go wrong and what could have been avoided. But I mean, I think the reasons why it's different in the UK. I noticed one of your economists, Chris Evans, writing one of our papers this morning, said it's a combination of good planning, good action, but also a bit of good luck. It is easier to manage an epidemic in an extremely large country with a small population than a small country with a very large population. Just speak, and I did train in epidemiology many years ago, and I would rather manage an epidemic here or in New Zealand than I would in any European country. Our figures are not actually that dissimilar from the rest of Europe. We're up there alongside France, Italy, and Spain. It's not a good place to be. We're slightly worse than Germany, and there's a huge debate going on as to why that is. But it's not radically different, whereas yours is radically different. And then I think some of the bad luck bits, as it were, was that we were probably a little slower to respond. We had a government that was still obsessed with Brexit and maybe didn't react quite as quickly as you did and other countries in Asia did. We had a population that our last pandemic was swine flu, and that really didn't amount to very much. And we already knew that most people felt that this was going to be similar. This was just going to be flu again. We had a big reaction public health-wise to swine flu, and it's generally felt that it was an overreaction. It wasn't, in fact, it wasn't really necessary. Doesn't mean we shouldn't have done it, but everyone remembers that, and we knew from the polling that most people felt this was the flu, and the government had cried wolf before, which makes it rather difficult to introduce really draconian public health measures so quickly when the population looked fairly clear would probably not have cooperated at that early stage.
Simon, if I may, Kamalini was very generous in giving a lot of credit to the Australian community in that the way we reacted. Do we have any reasons to know that once the government gave the orders, and the government might be slow, that the UK community did not or did react with the same rigor and engagement?
Yeah, they definitely did. In fact, it was more than that. As the level of anxiety grew in the population, and we were doing, the government and other people as well, including ourselves, were doing rapid polling measures, anxiety did start to rise quite quickly. And then what actually happened was the public then, for a very short period of time, beginning in March, was ahead of the government. So already big gatherings were closing, pubs were closing, restaurants were closing, traffic was going down. And if you actually look at it, you can see that almost half of the behavioural change had already happened before Boris Johnson opened and actually mandated it. So half of it had already happened. Yes. And the compliance then is truly remarkable. I don't know that anyone really fully appreciates the sheer scale of the behavioural transformation in a very short period of time. And compliance at the moment still remains remarkably high. It's in the high 90s, mid to high 90s, which was also unexpected. And the projections were not quite, we didn't expect quite so many people to comply quite as quickly as they did when finally we
Simon,
got
on that note, let me turn to Warwick. So Warwick, we made the right decisions, the community responded in the right way, got lucky, so everything worked out. And where does that leave us in the end economically?
Well, the economy's taken an enormous hit. Actually, the global economy's taken an enormous hit. And the International Monetary Fund, their forecasts, I was working with the International Monetary Fund in Washington through February and giving presentations on my early work. They're their last forecasts are very optimistic. I think the world economy will shrink by at least 10% of GDP. This is a very large economic shock. Just to come back to Simon's point, I mean, we are lucky, but I always like to look at the data. And if you look at Sweden took a totally different policy strategy. They've got a much smaller population. The economic forecast and the data coming out of Sweden is as bad as it is coming out of Australia. So the economic costs of the measures we took probably were not very big compared to the damage done by the pandemic itself. So I think, at the beginning of this debate, we had this false argument about trading off health with economics. That's just not the place we were at the beginning of March. You cannot have a functioning economy without a good public health outcome. So you deal with the pandemic first, and then you're in the position we're at now, where we start talking about trade-offs. And so looking forward, we have to make some decisions about where do we start opening, which part of the economy can we get the biggest economic return for the lowest risk. And that's a more rational debate than the debate that we were having in the Prime Minister's dining room in March, where we almost went for the British model, and thankfully we didn't.
Right, but when you hear this talk of elimination, which presumably is using the measures we're using, but perhaps more intensively with greater rigor, etc., and chasing down every single thing, do you see an economic trade-off there?
Well, the question, I think the two approaches are very similar, because even controlled adaptation, you have to get the infection rate right down. You can't let them hover around an R of 1 and then hope that it doesn't jump above. You have to push it down. The question is, how much are you willing to pay from an economic point of view to eliminate the last couple of cases? And my view is that that's where the trade-off is. And it's pretty clear that we can manage this with everything that everyone's spoken about. We've got to have testing, tracing, isolating. We've got to be very smart in developing different ways of undertaking economic activities, changing economic interactions. And I think we're in a very good place. We're in a place where almost no other country is, except for New Zealand and South Korea. And so I think the luck was there, but I think it's overplayed. It's overplayed by the people who made the wrong arguments at the beginning. We had some bad luck. We had a couple of cruise ships that we should never have let in. That was bad luck, but we managed it.
Okay, so
can I say something about good luck? Because I think it's important that I don't think this is around good luck. And I hear this often, oh, Australia's done okay because you're an island, because it's summer. But actually, between mid and late March, when the epidemic was taking off, in the middle of summer or the end of summer, the doubling time was every 2 days. The outbreak was proceeding at exactly the same rate as anywhere else in the world. And I think that we had good management and good timing. And good management because Australians are very conscious about what's happening in Asia. And so from early January, and I know this amongst my colleagues around the world, no one was really thinking about coronavirus. But across Australia, everyone was thinking about it back in January. They were designing tests. Everyone was very worried about it coming here. Good management, and I think this was brilliantly and great timing, was stopping flights from China on February the 1st, which for me, I thought that was a terrible decision. I'll say honestly, the WHO was saying, you know, blocking flights is the worst thing that you can do for a global health crisis. But it saved Australia because we actually stopped seeding at the very beginning back on February the 1st. And at the time, Europe had not stopped flights. The US did, but the US was still getting people from China coming from other places. We stopped flights from China and stopped them coming from other places. And the last thing about good timing was that when we had to go hard, which was end of March, we were already seeing what was happening in northern Italy and beginnings in New York, which meant that the Australians were very comfortable. They were begging for harder measures because they were looking around thinking we're going to be New York and northern Italy. So I absolutely do not think it's about being an island or being summer. It would have taken off here as well, and we had all of these other factors in place.
I think that's a very good point you make, but because if you track another country which was very similar to ours, Simon, and that was Canada. For the first 60 days of this pandemic, we were within 10 cases of each other for a period of 2 months. And then something changed in late March, and the speculation is that it was the snowbirds coming back from Florida in large numbers, and it was the young kids who'd gone to March break in Florida coming back, and they brought the infections and particularly seeded the aged care homes. And today, Canada has 45,000 cases, and we have 6,000. And just a month ago, both of us had 4,000 cases. So that tells you what we did differently, but also tells you how quickly all of this could change. So that brings me back, Kamalini, to something that you said, that in elimination, it's very important not to focus on an individual, but on a transmission chain. What implications does that actually have for when you're managing it through testing and tracing?
I think it's two things that the first, I think, is you focus, going back to what we know. So it's the funny thing is when I talk to highly experienced epidemiologists who've managed high-risk infectious diseases for decades, we all think we can eliminate it, but we can find every case, and because we know how it's done, and I think we have the tools to do it. So first of all, I would say before the transmission chain is going back to, if you're close to 0 cases, you don't know that unless you have the right testing system. And the right testing system, it's failed if it's looking for the disease, okay? If you want to prove that it's not there, if all you're looking for is the disease, your system doesn't work. You need to look for indicators of the disease, of risk of the disease, or that you're able to pick it up. And that's why getting everybody with what we think of as the most efficient constellation of the symptoms presenting to get tested is the way we will find every case, but more importantly, be confident that there aren't cases. So it's not complex. And then with transmission chains, it's just that this is an infectious disease with person to person, human to human transmission. Every person who has it is linked to someone who gave it to them. So if you can follow that, and you know, I've done this in war zones, you can do it,
okay, right? Kamalini, most of us haven't done it. So give me a number. When you find a contact, how many upstream cases do you usually have to, when you find a case, how many upstream cases do you usually have to go and work with, and how many downstream cases do you have to work with?
So it depends on how long it's taken to find that case, right? And if you're looking for people with mild disease, what we know is that people, the most common is they'll develop symptoms within 5 days of exposure. So if they come on the first day of symptom onset, then we need to look, and we look back 14 days, right? Because almost everybody will get disease within that incubation period, and we look for contacts. Now that can vary currently because people are social distancing, because we've limited mass gatherings, because there's not people going on flights. The number's going to be small, except for perhaps certain individuals, essential workers who have larger contact.
Okay, got it. So now, just to remind all our listeners, you can certainly start chatting in your questions. So if you're typing them, you can type them in. They're being collected over here. You can upvote questions, but also if you would like to ask a question, do just email the address that I gave you. We will get to questions in a little while as I just wrap up with the panel here. But look, we would have to concede Australia is in a lucky place, and we might land up eliminating it locally. We won't land up eradicating it. So for the rest of the world, we'll need treatments, and ideally we'd need a vaccine. So Steve, what are your bets on treatments?
I really think that a massive number of things are being thrown against this disease, and the number that will work will probably be quite low.
Okay, so can I get one out of the way? The very famous hydroxychloroquine. Tell us about that.
Well, hydroxychloroquine is one of the interventions being evaluated in REMAP-CAP, and it'll be the greatest professional disappointment of my career if it turns out that REMAP-CAP proves that hydroxychloroquine is effective.
All right, we'll leave the double negative there, but what are the other sort of more logical treatments that you think are in the running?
So there's a whole cascade of different treatments that sort of correspond to stages of the disease as it evolves. I think one of the challenges is trying to evaluate a range of different treatments at different stages in progression. Probably small molecule antivirals will have the highest likelihood of success early in the course of disease. We're learning rapidly about the cytokine storm and the changes that occur in terms of inflammatory response, and being able to deliver treatment at the right time as that cascade of events occurs is also likely to be critical. In the very near future, in fact, today, I believe, REMAP-CAP will have convalescent plasma available for patients in the United Kingdom. And so that's another form of specific antiviral therapy, again, for which timing may well be critical.
All right.
REMAP-CAP will introduce in the near future a domain related to anticoagulation, because it seems as though some of the pathological and pathophysiological abnormalities relate to activation of coagulation in small vessels in the lungs, possibly small vessels in the heart. And lastly, there's an axis related to the ACE pathway, which is involved in viral binding, that has some form of promise.
So there's lots of options, but you're not picking a particular winner. So let me turn to Sharon and ask her about vaccines. Of course, that seemed to be the panacea if we could get there.
Well, vaccines are the only way we've ever eliminated other infectious diseases. Prevention much better than cure. And yes, a lot happening in vaccines. There's an estimate of around 70 different vaccines being developed currently. But what's really interesting to me, given that we only discovered the virus in early January, is that there are 7 vaccines now in clinical trials, 4 outside of China and 3 inside of China. And some of these clinical trials are quite large. They're all phase 1, but some of them are quite large. So the sort of front runners on the vaccine are one coming out of Oxford. This is a chimp adenovirus, or a weakened adeno-cold virus that infects chimpanzees. It's been used actually widely for vaccination, particularly in HIV and other areas. And it has a piece of the coronavirus protein in it, the S protein, which is the spike on the outside of the virus. Interestingly, they've already tested in macaque models in the US, and it protected 6 monkeys from infection. So it looked good in a macaque model, and now started, I think, 5 days ago in phase 1 studies, and they're planning to vaccinate against placebo, in the range of thousands of people. So very rapid rollout of using this chimp adenovirus. The other main area virus vaccines have been tested are a totally new kind of virus, totally new kind of vaccine that uses the genetic code of the virus, or RNA vaccines. And there's one from the US, one from England, one from Germany.
But tell us about the Australian one.
And there, of course, there's the Australian one. I didn't mention that. Very excited about the Australian one. Didn't mention it because it's not yet in clinical trials, but they're saying they're planning to get into clinical trials very soon, I think in June. That comes from the University of Queensland, and it uses something called a clamped trimer. So it basically takes the spike protein, that surface protein, and it clamps it into a configuration which induces a good immune response. They announced just yesterday, I think, that in mouse models, this is inducing immunity. And in fact, that testing was done here at the Doherty Institute, and they're planning now large-scale production and then phase 1 studies in June.
All right. So, Sharon, there's a lot of excitement about vaccines, and in some sense, that is really the only final exit strategy, other than everyone around the world getting their own exposure. You once told me something very interesting about HIV, of course, something that you worked on for decades, about vaccines and HIV. Just tell us that anecdote again, because it has stayed with me.
Okay, so when HIV was first discovered in the early 80s, Surgeon General of the US was famous for saying, standing up and saying, this is a disaster, this is terrible, we will have a vaccine in 2 years' time. And I think that was back in 1983. And here we are in 2020 with enormous amounts of money and research for HIV and no vaccine, except we've totally changed the face of HIV over the last 3 decades. And that's been through, good public health, great advances on testing, and the main factor is antiviral drugs, which started off complicated and toxic, but now are cheap and widely available, and 60% of people living with HIV are on those drugs.
So vaccines or drugs will somehow find hope, but during that period, there'll be hundreds of people, well, millions of people who've been isolated, billions now. If you count in India and look at the total numbers, it's just staggering. And if so many will get affected as cases, and of course, many will die. Simon, what do you think will be the net impact of this and all the economic and social dislocation that goes with it?
I mean, awful. What could one say?
I'm a psychiatrist. I thought you'd say something.
I know. Well, sometimes normal language is just better. It's just awful. We don't know. I mean, we did early on, we looked at what was known about the impact of quarantine before this started, using mainly examples from Ebola and from SARS. And that wasn't great. There have been 26 mental health studies, and 25 of them found an increase in mental health problems as a result of quarantine. That's not to say you shouldn't do quarantine, but like all interventions, it is not without its side effects. And in some, they were quite profound. But that still is, a much smaller scale enterprise than we're facing now. And we sometimes go back in history, and in Great Britain, we often say the cultural example we use is we got through the Blitz, we got through the war, we'll get through this. But even that's not a very good analogy either. We did get through the war and the Blitz, but we didn't practice social distancing for the whole time. We still kept our pubs, our restaurants open, we kept our theatres, our cinemas open, and our public spaces. Even though that caused casualties from time to time, it was still considered more important to maintain the social fabric. Now we have this intervention of social distancing, which actually gets to the heart of what it is that keeps us going, which is our social networks. So I don't know what the long-term implications will be. We can already see in our population, and I don't know where things are definitely much less optimistic than what's happened in Australia. So this may or may not be the case, but if you look at the moment, the best data we get is from opinion polling, both private and public. We haven't yet got the results of rather more complicated and in-depth mental health studies, but they're coming. Is that already about, I would say about 40% of the population are coping reasonably well. All things considered, they're complying, they're not too disturbed. 40% of the population are not coping well. They're definitely struggling, and much higher rates of, excuse me, of anxiety and depression. They are complying 100% with the restrictions, and indeed, the general view is they should be stronger than they are now, and they are fully in favour of greater police powers, largely because this is a very, very frightened section of the population. And where you also see is a very clear evidence that even when we lift these restrictions, a lot of people will not go back to where they were. They are reluctant to go to work, particularly in public service. They will not send their children back to school. They will not go to communal places. They will not go to pubs and restaurants. So even if we eliminated all restrictions tomorrow, which of course we're not going to do, but even if we did, we would not see people returning to normal for a very long time, if ever. And then we have an increasing number of people who are really very fed up, frustrated, irritated, etc., who are complying much less and less likely to comply in the future. Now, if all this continues, we're going to start to see social fracturing, which has happened in epidemics in history. And that is, I think, where we get into very, very difficult areas as we come out of this. If the current consensus really starts to break up, if we go to immune passports, so those who've had this are able to do things that those who haven't, I think that will be incredibly socially disruptive, even if those passports were accurate, which at the moment they're not. But if they were, then I can see real trouble ahead in society.
Well, Simon, we've heard about those people who are making medications for viruses and vaccines. What's the answer for this?
For what? For the kind of public mental health approach?
Yes.
I mean, I think there's two things. The first thing is slightly ironic that this time last year, I was spending a lot of time on the media trying to suggest that social media was not the cause of a great breakdown in youth mental health. But nearly a lot of my colleagues and all politicians and commentators felt social media was to blame for the rise in mental health problems in young people. Now, of course, we now say social media is our savior. You know, it keeps our children together, helps them to get educated, and is an endless source of very funny videos. So there's a sudden change there. I think that's quite curious, the way that we've gone back to, I think, to appreciating that it's the medium, not the message. Clearly, this is not a thing. We cannot counsel ourselves out of this problem. That's impossible with the millions of people. So we're already, and we know also the groups that will be most vulnerable. We're already seeing this. We're already seeing that those who have previous mental health problems are far more vulnerable, and that's already showing. We're already seeing that this confinement that we're in now is rising rates. I don't know if this is the case in Australia, it's very much the case in Britain. I'm acutely aware that my son is a child protection social worker, and a rise in domestic violence, quite dramatic actually, and a tremendous.
So Simon, so we're an interesting fulcrum bringing it back to Australia. In some sense, the virus numbers are down. So I'm now turning to you, Warwick, that there could be two approaches. One is to go really hard to get to that last case. And the other, and I'm just setting up these two there, I'm setting them up as binary, though of course all of us understand the world isn't that black and white. The second is, look, we get some numbers between, I'm just picking something here, between 10 and 50. Now I realize it's perilous holding it between 10 and 50 because, say, like Singapore, it could easily go to 500 in your effort to hold it between 10 and 50. But if those were the two options, and one allowed quicker and greater relaxation of business, we're not going to footy as yet, just more business. From your point of view, where do you see the trade-off?
So this is complicated. And the reason it's complicated is the other factors that were important for our success was communication and coordination. The federal government and the state governments coordinated their response. If you want to know what happens if you get that wrong, you look at the US with President Trump's daily briefings and the war between the federal government and the state governments. That's creating a humanitarian disaster in the US. So Australia needs, it's not a question of how quickly you open, it's a question of how carefully you design the policies. Where do you actually incur the biggest economic gain for the reduction for the amount of change in health risk? So it's not a number. Economists like numbers, but it's not a number, it's a set of policies. And I think it has to be coordinated across states, and it'll be different in different states because they have different sets of issues, as countries have different sets of issues. So I favour the controlled adaptation just because I think the economic costs and the psychological costs that Simon's talked about, they're real. I mean, we've got the unemployment rate's probably going to hit 15%. That's a lot of people out of work. That's a lot of destruction of economic activity. You have to take that into account. It's not just saving lives that the epidemic would have killed, but it's actually creating a society that's not falling apart.
Warwick, from your point of view, if we had to stagger and phase it, what is the lowest hanging fruit in terms of bringing us the biggest amount of economic activity back without exposing a large population to more? So if one could think of it that way, what would be the lower hanging fruit in that case?
So what's interesting is that not every economic activity has gone into decline. If you look at where the biggest drops are, they're in gyms, they're in travel, they're in cafes and restaurants. But there's been an expansion in certain parts of the economy, particularly in alcohol, which is a bad one, but also in food delivery services, online activities, purchasing online. So there's been a big shift, and gambling. I mean, there are goods and bads in this whole list, but there's a big shift in this pattern of spending. There's been a big increase in the amount of people spending money on IT and furniture for office works, for working at home, etc.
Oh yes.
So there's a lot of activities that are shifting. What I think is needed is a lot. You wouldn't just ask an economist to design this. You have to ask a whole range of different specialties, epidemiologists, psychologists, etc. So I won't give you a firm answer, because I would just sit down in a room and we would talk about it as we did in designing this particular report that just came out today. It's not a simple answer. It's complicated.
No, it isn't, and I think that's the very good point. Now, I realize it's time for us to turn to questions. So first, I want to thank all of you for writing in your questions and upvoting them, and we have quite a few of them. But the question which is top of mind for people is, given where Australia is today, and Kamalini, you might want to go at this first, and then Sharon, what are the kinds of infection numbers which will tell you that there is a second wave coming?
So, do you want me to go first?
Yeah, why don't you, and then Sharon, yeah.
I think this term second wave comes from the Spanish flu outbreak. And I don't like it at all, because it was waves of transmission across the whole community. People are calling what's happening in Singapore a second wave. What is happening in Singapore is the fact that people who had no access to welfare, no access to money to buy food, who were living 20 to a room in hostels, and who were not had no access to healthcare, had unrecognised transmission of the disease for an extended period. Now, that is not a second wave. That's a poor management of a high-risk population. So I would say, and if you look at the outbreaks in many settings of COVID-19, it's exactly the same. So again, going back to what would tell us that we have control of this disease is everybody who needs to be tested coming to be tested. So I don't want to talk about numbers. That's what I will say.
Oh, you're also smart. You don't want to get pinned down into a number that might go wrong. But
that's what I think. I think we can get there very quickly in terms of a really effective surveillance system. And that's what the key indicator is.
I'm just being provocative, but I think your message is the important one, that it might actually be, counterproductive to focus on a number when we really have to focus on the strength of the system and its ability to respond.
Shall I say something very quickly? So in industry and things, we have these things, HACCP processes and things, where if something goes wrong, we failed. What we want is to pick up much before in the medical system. That's what we have. We have checks and counter checks and counterbalances, so that we don't actually get to a point where our system's failed and somebody dies. Right. So that's what I'm talking about. Picking it up much before we have to wait for cases.
All right.
Shitij, could I just add to that? Because I think what's important here is that the policies that we design have to be flexible. We're learning by doing here. And the big mistakes people make is when they believe they're right and they set up a policy framework and they push it until the very last minute until they've proven absolutely that they're wrong and they change. That is exactly the wrong way to do public policy. And I think that's the risk that we've seen in the UK, the US, and other countries.
But Warwick, you're almost asking for an agile public policy. And to most people, those are two words that don't usually go together, but these are new times.
Well, I think what's key here is communication, and you have to have credibility. If your government is seen to be useless, no one will believe you and none of the public health interventions will work. So you have to establish credibility. And I think Australia's done that, not under the bushfires, but they're certainly doing it now. And so I think we've established over the last few weeks that the federal and state working together across political parties, getting expert opinion and having expert opinion at these press conferences, that really does build credibility and people will believe that the government's doing the right thing.
Yeah, and it's probably just not the government, you know, it's using science and the best evidence to inform your policies. And that's, I think, where we're seeing, have seen quite a lot of mistakes internationally, of course, within the US, and then maybe in the early phases of the UK response as well. So, you know, the resources to maintain the testing, the dialogue, and the ability to provide that expert evidence to decision makers, that's worked pretty well this time.
Well, you know, I realize none of you are political scientists, so all of you feel free to jump into this question. But the truth of the matter is, if I would have asked you in the end of January, you know, how credible is our government here in Australia, I can pretty much guess what you would have said. But look at it 2.5 months later. So this was not necessarily a government with very high credibility for these kinds of things going into this episode, but it has managed to come out of it, establishing a very high level of credibility and getting great engagement from the population at large. What did we do differently?
So Shitij, if I can come in here, because I spent a lot of time talking to at the Parliament House.
Well, you are there, yes.
What happened was the state governments did very well in the bushfires. The management out of New South Wales and Victoria was done. That's where they're on the ground, they're managing it. The federal government was really just providing resources and some leadership, which was questionable. So they had a very good system of governance between states and federal. It's a federal system that's very different to what we've seen in the US. And I can't speak about the UK for Simon, but the US is the classic example of what you don't do. And that's what we need to learn from, as well as what we got right.
Well, we got right.
Early March, it wasn't that rosy between states and federal government. There was quite a lot of tension there actually about how hard to go, and but I guess, you know, that's also the benefit of a federated system. You've got some diversity of views. You know, Victoria had a different approach to New South Wales. That probably pushed the federal government a bit. So but it's both ways.
It's one thing having 7 or 8 different views. It's one thing having 52 different views. But we leave that aside because we have someone who's going to come on live and ask a question. Something that's on all our minds. When do we get to travel again? So let me invite Professor D.U., an immunologist at UQ in the Diamantina Institute. Now, magically, there you are. I can see you. We're waiting to connect your audio, and hopefully that'll happen soon. Are you there, Professor Yu?
Oh, hi, this is Steve.
Please go ahead and ask your question.
Oh, okay, all right. First of all, thank you very much for organizing this meeting. And I'm an immunologist at the University of Queensland, the Diamantina Institute. Actually, I'm doing some research around COVID-19. I'm an immunologist. I'm particularly very excited from what Steve just mentioned about this cascade immune response. We access some patient data, clinical data from patients in China, and try to use mouse model, try to understand the immunopathology underlying the disease severity. But my question today actually is not about immunology. As we can see here is basically the whole Australia largely stopped international travel. So I just very curious about how we can gradually restore the international travel step by step from epidemiological perspective, from medical perspective, or from economical perspective.
Okay, who's going to take a first shot? Kamalini, Sharon, Steve?
I'll take a few. Hi, Dee. I know Dee well. I thought you were going to ask me a vaccine question, Dee. You've gone into epidemiology. I don't think we'll see international travel for a while, personally. I think while we've got a lot of work ahead of us, either with long-term suppression, the world around us will be at different stages of the outbreak. We may see international travel with New Zealand, who will be at similar stages, and these decisions will be really hard. And if we do see international travel, you most likely will have quarantining when you go out and quarantining when you come back, and that's going to make it really difficult. So I can't see we're going to have much international travel until we've seen a dramatic difference in the outbreak or we have a vaccine. So I think.
All right. Thank you very much.
Virtual conferences, which are horrible.
Yes. So
Shitij, can I give a different perspective to that? Because I think we have to distinguish. So Dee, we have to distinguish between travel, it's tourism, and travel of a longer term nature. Now, one of the key economic benefits we've had in Australia has been immigration, one-way movement and they stay. Or if foreign students, one-way movement and they stay for 4 years. They're big economic drivers. And so if you do want to actually kickstart the economy, you want those types of people to come into the country. And you can easily do that if they can transport themselves, which is a question. But once they get here, you can quarantine, you can have very clear processes in place for dealing with the long-term migration of people. And I think that's an important policy that we need, because the universities are hemorrhaging revenue, but actually in terms of driving economic growth in Australia, that is a key driver, and that has to be done in a very imaginative way.
Very good.
Warwick, the world has moved on to Zoom. How important is business travel to the economy?
So this is another positive aspect of this crisis, is that there has been for decades, I do work on productivity and why do we see technology everywhere but no growth in productivity? And the answer is that people just haven't picked up the productivity gains coming from technology that's laying around. What we're seeing is a massive shift. People are moving, industries moving very quickly to take on board new technologies. Now, not now or not in the next year, but down the track, you might see a very large shift that we've been looking for 20 years in the technological innovation driving productivity growth. It's real and it's big. I mean, I've been to Texas, I'm going to Stanford next week, I'm doing all sorts of stuff, and I don't have to get on an airplane and kill myself. So it's a really big benefit personally, but also from an industry point of view. We're transforming the way we live and we're transforming the way we're doing business.
And
I've got a better understanding of time zones than I used to.
Yes. You know, that's the problem for us if travel stops, is that we get stuck in the wrong time zone. They'll have all those international conferences and we'll have to get up at 3 in the morning to attend them. But anyway, we've got Paul Miles, who's got some interesting questions about how these viruses might be mutating. So Paul, we'll wait for you to come in. It says connecting to audio. And Paul is, of course, a fellow of the Academy. So welcome, Paul. You're connected now, but your mic seems to be on mute. Paul, if you can hear us, your mic is on mute, so we can't hear you. There you are.
How's that?
Very good. Go ahead with your questions, Paul.
Again, it's a question for Sharon Lewin, so lovely to hear all of your opinions. I'm interested in what's the likelihood of the coronavirus, the SARS-CoV-2, actually mutating to a less potent or non-virulent form?
Hi, Paul. Nice to see you as well. I think there is not a high chance of seeing significant mutation. We haven't seen that so far. SARS-CoV-2 is an RNA virus, and RNA viruses copy themselves. They always make mistakes. So you see slow mutations, but we don't see dramatic mutations. And usually what drives mutation is some sort of survival of the virus. And while you've got a population of people who are non-immune, then there's no driver for mutation because it can infect everyone. There's some discussion that over time a virus such as SARS-CoV-2 can become less pathogenic, but I don't think we've got any evidence to see that it would go that way. So at the moment, no great changes that we've seen so far over the last 3 months.
Paul, just a second. Can I just extend your question and ask Sharon, because it's been asked on the chat. Okay, the virus might not change, but what's the likelihood it'll develop seasonality? So, you know, it might go down and just like flu come up in a big way.
Yeah, this issue is spoken about a lot, about whether particularly in Australia, we will see worse increases in infections as we head to winter. There's a number of reasons why viruses like flu get worse in the winter. First of all, crowding inside and therefore you're close to people. Flu viruses survive longer when there's less sunshine and at lower temperatures and with a lower humidity. We don't know whether any of those factors are actually relevant for SARS. coronaviruses. They certainly spread in summer months, as we saw in Australia, as we've seen in Singapore and in hot climates. But that question is actually not yet answered, and we'll know that watching what happens in the Northern Hemisphere and what we'll find in the Southern Hemisphere.
Thank you. And Paul, you had another very important question. We've been talking about testing, and almost testing everyone we can find, but that of course raises an important question. So why don't you go ahead?
Yeah, so again, the current prevalence in Australia is extremely low. The PCR testing is not perfect, particularly with sampling techniques. So what's the benefit of testing, given that the actual negative predictive value will come from the results most often? Does it really change what we already know?
All right, Kamalini, for this, that if we are going to have such low numbers, given all the sensitivity, specificity issues, can you just keep testing for that one case amongst 25 million?
Going back to my point, we should be testing to prove that it's not there. Now, the best way to achieve that outcome is to do what we've learned from other diseases, which is to make sure we're testing enough in the right people. And that is about community uptake of testing for the syndromic case definition. So those who need to present to testing, we want that proportion to be very high in the community. And so that's why that's the number we should focus on when we're heading towards very small numbers, not the number of cases of COVID we're detecting.
Fair enough. But that leads to another question that's come up on the chat, which is the number of asymptomatic people. And of course, this has, to me, become the most controversial issue, because you can look at estimates and they vary by a factor of 100 at the moment as to how many asymptomatic people there could be in a community. So Sharon, your thoughts on that? What do you think is the right estimate or a better estimate of the number of asymptomatic people who got the infection and now have antibodies?
We don't know the answer to that yet. And that's because the tests for antibodies or blood tests are not perfect, lowish, not super high sensitivity and specificity, 70 to 80% roughly, as opposed to PCR tests that look for the virus, which actually have very high sensitivity and specificity. I was going to get back to that, Paul's questions around false positives and false negatives. So there's two issues with asymptomatics. There's the more important issue is how many people are virus positive and asymptomatic. Therefore, they actually have COVID-19 and they can be transmitting. And actually, it's pretty high. Overall, there's been some very large studies. Probably the best one, I think, is a very large study in Iceland. And about 50% of people that have a COVID-19 positive test were asymptomatic when they do non-targeted testing. So asymptomatic excretion of virus is quite common, though they say most of those people eventually develop symptoms 3 to 4 days later. So that's one issue about asymptomatic carriage and excretion. That's probably the biggest concern. The other is people that have infection, never know they've had it, or very mild disease, and therefore now have antibodies. And basically about 80% of people will have mild to moderate disease. How many people have absolutely no symptoms and become antibody positive? I don't think we've got a good handle on that yet, because we just don't have good enough antibody tests. I was just going back to the false positive, false negative for Paul, which is a good question. Because at the moment, when we're talking about mass testing in Australia, we're talking about looking for the virus, PCR testing on a throat swab. We're not talking about antibody testing yet. Antibody testing really is not going to be very useful for the very large base population testing for us, because the sensitivity and specificity is not good enough. Sensitivity and specificity for the PCR tests, not really published, but it is high. And we know because most PCR tests are very high. And I think a good example of this is how we screen blood. So we screen blood bank donations, very low pre-test probability of being positive for HIV, but we actually screen our blood supply with an HIV PCR test, the same sort of test. And there's a very small rate of false positives, and there are false positives with the PCR test for throat swabs. And what I think we will have to do when we're doing lots of testing, and even now we're turning up 10 positive tests, doing 20,000 tests a day. How do we know they're true positives? it would usually be repeating it on a second test or taking a second swab, because people, when they're infectious, will be positive for, on average, 7 to 10 days, and some people out to 28 days. So there will be this issue of false positives for PCR tests, but we're not, serology is a whole different story because we haven't got good enough tests for serology.
Okay, fair enough. There's another interesting observation, and I'd like to hear your thoughts about it. When all of this started, people were looking to Singapore. It was sort of like the poster child of getting it right. They were all the things that they'd been through SARS, they knew how to respond, they set up a national center for disease control that's all got all the things in it. It's a state where people are very compliant, they download their apps, they do what government tells them. That's why it's all going right. And of course, now the picture is very different. And then, of course, Canada was doing very well, and they said, look, it's learned lessons from SARS, and they were there, and that's not looking very good. So what do you think are the lessons we might take away from this to prepare our system for the next time something like this comes around?
I think Kamalini made the relevant point for Singapore, is that there was a group of individuals in the society that had the disease and they weren't testing and they weren't dealing with that particular group from a social point of view. So I think her answer to that was very clear.
I was going to say, for me, what we take away is that, we have universal healthcare, an excellent health system. We have welfare. I know many people who are, because of job seeker and things, who are able to stay home. So I think that's what we take away from this. That's how you manage infectious diseases. You make sure people have a decent health system and decent standard of living.
I mean, there has always been this evidence that equality in a society leads to better health. And I'm wondering, Warwick, if there's like a correlation between the Gini index and the outcome of this pandemic, that countries that were more unequal after taking care of other factors did worse.
We've got Sweden, that's the outline.
So I think, I think, but the answer here is
policy.
But again, I think I don't know the data, we'll wait and see, but I guess we've got very simple outliers like Sweden. What's really important though is it's not really the importance of investing in your own public health system that comes out of our analysis. It's the fact is, if the pandemic breaks out in a poor country, and usually they do, and that country cannot deal because they haven't got the public health system to deal with the outbreak, it's already too late, or it's much harder when it gets to you. So for $1 spent, you're better off spending $1 in a poor country than in your own country in terms of public health, because you can actually, prevention is better than cure, as Sharon says. And so the big lesson is we live in an integrated world, and the global environment is integrated, the global economy is integrated, people are moving around everywhere. We have to actually deal with the global issues. And I mean, what I was working on before I picked up my computer to do the pandemic was antimicrobial resistance. That is bigger and far more economically costly over the next 50 years than what we're going through now if we don't deal with it. And yet nobody's investing. No one's investing in animal husbandry, animal research, in any of the antibiotic. These areas aren't being invested in because the corporations don't have the incentive to do it. So I think we've learned that we're a global community, and we need to worry about the people in the countries where these diseases emerge as more than we have to worry about it in our own backyard.
But I like your focus on prevention, and let me use that to perhaps ask Simon. Simon, is there something societies could have done to actually prevent themselves and make themselves more resilient against an episode like this?
I'm not so certain that the different rates going on in Europe are due to a whole series of mistakes that were made. I'm not so convinced by that argument at the moment. It is still early days. I suspect the biggest differences will lie in some of the things we were talking about earlier. We have a very good healthcare system, actually, as does France, Germany, Italy, and Spain. And yet we are seeing, 1,000 deaths a day. Our NHS actually responded unbelievably to this. Everyone talked about the fact that Chinese built a hospital in 10 days. We built one in 5 days, which came as a shock to all of us, actually. She would be shocked as I was. see the NHS actually perform far better than any private institution could possibly have done in creating a 4,000-bedded hospital in the centre of London, which now isn't actually being used, but the capacity is there. So I think we did respond very quickly. I think there were some nuances at the start, but I still think they were mainly influenced by the different demography, the different population densities, the different travel that we have. It made it very difficult for us to meet our borders. And I think
that's responding to the sort of infectious part of the virus. What about the psychological consequences of it? Can you put
I honestly think it's too early to say. I think it's absolutely, I did make the point earlier that the greater the fracture that we get, and if we look at the history of pandemics, which have had some appalling long-term social consequences in history around the world, even very small ones. The anti-Irish feeling in this country, in Great Britain, began with the cholera riots in Liverpool in 1848, lasted for over 100 years, and that was a relatively small thing. But if we come out fractured, if at the end of this it turns out that some people have done better than others, some people didn't play by the rules and others did, some people have been absolutely ruined and others have become very rich, or a particular group is blamed for this, which doesn't seem likely at the moment, but could happen. And obviously the US, I think, is more vulnerable to that. The consequences will last for many generations. We have two views, don't we? There are some people who are seeing a rather utopian outcome, and I think you were going slightly that way, that we will reduce travel, we will become greener, we will become more, we've had quite a few religious leaders saying we'll become more tolerant and more kinder to each other. There's an equal number of commenters saying, actually, we're going to see the exact opposite. We'll go back to protectionism, xenophobia, we will close, we will not we'll cooperate even less globally than we have done before. The fear of the foreigner will return, and a much more dystopian view. I think it's a bit early to say, but I'm more of a pessimist than an optimist on this one.
All right, let me then turn to the economist on this one and say, look, we've responded by throwing a lot of money at this problem. That's probably not the right technical term. You'll tell me what the right technical term is, Warwick. But how would you characterize what we have done as a government response? And if you were to compare it to what has happened across the world, how would you see that?
So it's good to see that the economists, although we're called the dismal science, there are some others that are more dismal than we are. Actually, I'm an optimistic economist. So the key thing is not how much you spend. And it's what Australia did, which I think is important. And again, Kamalini made this point, was we tried to stop industry from failing by supporting incomes. So we put in place income support for people who lost their jobs. We put in place income support for small businesses and companies so they wouldn't close. And we managed to keep the incomes flowing in the economy, because without income, there's no spending, and without any spending, there's no incomes. And so in many cases in the US had not this sort of policy. The US is actually throwing money at people who have some sort of influence in the government. It's really extraordinary. You've got to support the population at the same time as supporting industry. And we also had a completely uniform policy across the board. So we dealt with the health crisis. So we put money into health where it was needed. We dealt with the financial crisis. So the Reserve Bank cut interest rates down to basically zero, but 0.25%, as well as putting in place an enormous amount of liquidity, so that if anybody was having, if it was a run on the bank or some other problem, the money was there to stop that crisis. This was completely across the board, and we had all the fiscal measures. Now, this is different for Australia than the global financial crisis was in a number of key issues. We weren't having a financial crisis in Australia. We were hit with a crisis in Europe and the US. That was an external shock to our demand for our products. This is an internal shock and an external shock, and it's a demand shock and a supply shock and a supply chain shock. So it's a totally different problem. And some countries have taken the same policy strategies as they took in 2008 to this crisis, and they're spending a lot of money but not getting very much return for it.
So, Warwick, one of the things people say that if this Simon's vision, even for the short period, that we'll become more nation-bound with locked barriers comes true, Australia could enhance its manufacturing capacity and get back, the cars we used to make and all the other. What do you make of that? Do you think it makes sense, or do you think it's feasible?
Well, I think it's very, very expensive. I think the lesson here is not a lesson against globalization. It's a lesson against specialization with certain trading partners. So diversification is a much better option. So instead of relying on one country for our exports, we should rely on many countries for our export markets. So if something happens in a particular country, we don't get hit as hard as you would if you relied completely on one country. This is important because the next shock could be an Australian-centric shock. We might have a deep problem here, a climate-related shock. And if we haven't got access to the world economy, there's no way of buffering our domestic shock with the global system. And so it's diversification and cooperation that matters, not nationalism. Nationalism is a real big problem. But you're right, this is where a lot of people are advocating. It's not the answer, and it's very expensive to build your own car. It's very expensive to do certain activities. There are some activities which probably make sense from a risk management point of view, have certain production of certain medical equipment in Australia. Those sorts of things I could understand, but as a general proposition, diversify the...
Okay, well, thank you.
I'm knowing that personal protective equipment manufacture is a strategic industry.
And I'm willing to believe that was a good idea. And but you can switch very quickly. I mean, look at all the gin producers in Australia that are now making,
sanitizer.
Yes. Sanitizers.
All right, we're coming to the end of our times. I have a few questions, but I'm going to end actually with all of you asking you one question. So I'm telling you what it is right now. And what I'll ask you is, any such shock to a system often tells you a lot about who we are. And I'll end by asking you very quickly, what have you learned about who we are as humans or as a country through the shock? But two technical questions before that. One is, Sharon, probably you're in the best position to answer this. Can people get co-infected from COVID? If you get it once and you improve, can you get it again? And what does that mean for this venture of developing vaccines?
We don't know the answer to that, whether you can get reinfected or not. We can develop, there has been successful animal coronavirus vaccine, so it's possible to develop a vaccine to protect you from coronavirus. We haven't yet done one for human coronavirus. There's some suggestion from some of the work that was done in SARS-1 that you could become, in animal models, you could be reinfected after a primary infection. So we don't know the answer to that, but I'm quite confident that a vaccine could induce the immunity to leading to protection based on animal coronavirus vaccine.
All right, so last technical question to all of you. Simon may not choose to answer this. How many of you have downloaded the COVID Safe app? Hands got up. I see Ingrid on my side. Ingrid's hand counts. Kamalini?
Yes.
Yes. Steve?
No.
And I genuinely tried to download the app on my Samsung Galaxy 10. It's the latest Samsung, and it is not compatible with this.
So, you need to get an iPhone.
But I spent last night in a room with a patient with COVID.
Okay, good. So now, your views on that. Will it make a big difference? Kamalini, you first. You think a lot about transmission and this?
COVID app? Is that the question?
Will it make a big difference?
If we look at empirical evidence, it has been very useful for countries that have linked it to very effective contact tracing. So it's a tool that supports effective contact tracing.
And what level of penetration would you need in a population? Is the effect linear? That 20% get it, you get 20% of the effect? Or is there a threshold that we need to reach 60% for it really to make a difference in the efforts?
I think it's going to be like the infectious disease. There will be a threshold. And I think as we go, the effectiveness will increase exponentially. So where we'll get to a point where, even if a small number, and I don't know what that is, a certain proportion doesn't have it, it will have the effect we want. And we can see that from other countries.
Thank you. So, Simon?
Yeah, I'm just going to say, I'm sure the app's coming to the UK as well, and I think it is clearly one very helpful way when we get our numbers down. I would caution against the other view that has also been discussed. Another way out is this use of immune passports, dividing the world into those who've had this and those who haven't. And I think that's an extremely dangerous way forward. even if it worked, which at the moment it wouldn't.
Won't work.
All right, on that note, let me turn to what we have learned. So what have we learned about ourselves as humans or Australians or Brits through this process? Who's going to take a pick?
I'll start first,
Yeah.
because this is often said, but I do think we've learnt that humans are resilient, and we've just gone through incredible upheaval of our lives, faced major challenges, particularly, in the UK, US as healthcare workers, unprecedented stress on our healthcare systems, and yet we're adapting to that change and finding solutions. So that makes me really optimistic that we'll see an end to it. We've also learned that we've got a lot of systematic issues that we need to address as a nation in Australia and as a global community, and around how we think about infectious diseases and our risks. So a lot of work to do there.
Okay. Anyone else? What have you learned? Yes, Warwick.
So I think it's really important that we understand that institutions matter. Well-designed institutions matter. Well-designed processes matter, and relying on science for making decisions within institutions that can actually implement quickly matter. And so, we always have this push to dismantle certain institutions. We should rebuild the WHO. It's been debased, unfortunately, and it matters. It matters, and when you find out there's something wrong is when it really does matter. So there's a lot of international institutions, domestic institutions, and actually I think we've also learned to save for a rainy day. I mean, if we had had the sort of debt in the economy that some countries have got, 100% of GDP, we wouldn't be in a position to roll out the sort of packages we have. And so there is a case to be made for saving for a rainy day, both as an individual and as a country.
Good point. Anyone else? Steve? Yeah, go ahead.
The public health authorities and the mathematical modelers have been the absolute heroes of the response in Australia, and countless lives have been saved as a consequence of their decision making, which I think was made at times under enormous public pressure and with limited information. And I think that we all have an enormous debt of gratitude to those individuals.
It's remarkable coming from an ICU physician. We usually look at the likes of you, Steve, for saving lives. And who would think a slogan, equations save lives? But it's probably true. Kamalini.
Go back to what I first said. I think all of the things what Warwick said and things, it's all based on trust, the trust communities have in institutions, and that's related to public goods. And again, something else Warwick said, public goods are global public goods. So infectious diseases teach us that if there's weakness anywhere, then it's weakness everywhere. So I think we need to think of ourselves as a global community and invest in the public goods that recognize that.
Yeah, no, that's a good point. Simon?
Well, I've spent most of my life saying that people are more resilient than we think, and on the whole, don't panic. And I think, once again, we saw that people didn't panic. There was no civil, as long as the supply chain continued. Some people bought a bit, but that's not panic buying, that's just being sensible. And again, that's what we've seen, and this remarkable compliance with behavioural change, unprecedented in history. So that's the case. On the other hand, I also think we're going to see, and it's happening, all of these things were happening anyway. Everything has just been accelerated by this epidemic. As society becoming increasingly risk averse, this will definitely make us far more risk averse than we were before. And that all the things we mentioned about travel and things like that, there will be substantial change in behavior that we have not really foreseen. And the biggest one with, I think, increased anxiety, increased risk aversion, and an unwillingness to go back to how we were before.
Well, I can't say what we've learned about humanity, but I can tell you what I've learned about this evening, which is what a pleasure it has been to spend the last 90 minutes. It could have been longer, but I think we have to end. But I think I have also learned about how scientists across the world have collaborated. It is really remarkable how easily information has flown, how people have shared things, everything from virus sequences to model codes. And I think it's just an exemplar of it that, Simon, you got up really early in the morning to join us here in our evening. So I wish I could invite you over, but you now know you'll have to come and be in quarantine for 14 days, which is only better for us because you'll stay with us longer. So on that note, can I say thank you to you, Simon, first, but to all our panelists and to all those who turned, quite a few hundred of you, to listen to this. I hope it's been worth it. And for me, it's been a pleasure and a privilege as I hand you back to Ingrid for the final words. Ingrid, over to you.
Thank you, Shitij. Thank you all for your wonderful contributions. I think the message is that science matters, that we have many heroes through this pandemic, and we've just heard from our superb panel and chair who are all heroes. A number of the themes that kept coming out, the challenges ahead, sorting out which treatments actually work through rigorous trials, how we're going to get the right vaccines up and get them to the right people, how we're going to deal with the huge mental health impact that we've heard about, as well as the economic, governance and global challenges ahead. And I think we need to be flexible and nimble. And I think for that we need to congratulate ourselves, the Australian public, because we've shown with the, was it crushing the curve, Sharon, that we did, that we've really made a difference, and we need to hold on to that. So I'd also like to thank the Academy staff, our CEO, Catherine Luckin, Ida Gambaro and Katrin Forsland for all their work in organising this. The video of this webinar will be on our website at aahms.org, and please feel free to follow us on Twitter as well. So thank you again to the panel and of course our incredible chair, and good night.